Very good morning to everyone here. And as Dr. Asutosh has already told us, has reminded us that we're celebrating Mother's Day and we're celebrating Nurses Day, and we're also celebrating the Foundation Day of SGPGI today. I'm happy to be here, more than happy to be here, even on a Sunday morning. And I must thank Dr. Kirti for ruining my Sunday. And and her team for always being so gracious. And Dr. Abhijit, who personally kept in touch with me to make all the arrangements for this presentation. So we've already learned about fetal transition, and we've learned more. We even covered many parts of the pathophysiology of PPHN already. Now, there are different ways of looking at the same thing. So maybe the way I'm looking at things is a little different. And so you don't go off to sleep and you pay attention to what I'm saying. Okay. So I'm going to have a little introduction, and then we are going to discuss some risk factors for developing PPHN. We're going to briefly discuss the etiology and also the pathogenesis. So remembering that pathogenesis is the main thing that I have to talk about, I have fabricated this talk. So the definition. Now we are all quite clear about what PPHN is. So PPHN of the newborn is a syndrome of failed circulatory adaptation at birth due to delay or impairment in the normal fall of PVR, which occurs following birth, resulting in right to left shunting of blood and hypoxemia. That is what we understand by PPHN. The incidence is 2 to 4 per 1,000 live births. This is the report from a study which was done in low and middle income countries. And almost a fifth of these babies may die. 25% of those who live after developing PPHN have neurological sequelae. So it is something that really needs a place, requires a place on a Sunday morning, so that we should discuss. Types are primary, the cause of which is not known or is uncertain, and secondary, which is because of a whole host of other conditions. So there are certain risk factors for developing PPHN. Maternal risk factor: diabetes, hypertension, asthma, obesity, smoking, being more than 30 years old when you are having your baby, a urinary tract infection, and anemia. These are certain risk factors which may put the newborn baby at risk for developing PPHN. Then neonatal risk factors: male gender, elective cesarean, gestational age less than 37 weeks or more than 41 weeks, SGA, LGA, preterm babies. Dr. Asutosh mentioned in his talk that classically we think that it is the term baby or the late preterm baby who develops PPHN. But as he also told you, premature babies are also at a high risk of developing. So this is an article which was published in the New England Journal of Medicine in 2001. And we have always, this is the one that is telling us about this finding urea cycle intermediates. That is, we are looking at nitric oxide. So the precursor of nitric oxide was found to be less in babies who had PPHN, the cause of which was not known. And even the metabolites of nitric oxide were found to be less in babies who had PPHN. So that they are thinking that maybe there is something wrong with the urea cycle inherently, which is not appearing as a cause for the PPHN, and we are labeling this as idiopathic PPHN. So the etiology. So it may be idiopathic, 10 to 20%, and the other may be secondary. So there could be an abnormal transition at birth, like in babies who have asphyxia or in babies who have TTNB, that is transient tachypnea of newborn, parenchymal disorders, meconium aspiration syndrome, Topsilist, pneumonia, sepsis, RDS, abnormal development of the lung, a congenital diaphragmatic hernia, and babies, mothers who've had oligohydramnios, they are the ones who may have abnormally developed lungs in the newborn, and intravascular obstruction because of polycythemia, preterm neonates in the initial phase of RDS. Why I'm writing initial phase of RDS is that some babies who have RDS, they develop BPD. And later on, they develop PPHN. So not that, but this one, that early phase of respiratory distress syndrome. Then pulmonary venous hypertension. Now, classically, we do not include congenital heart disease as a cause of PPHN. So we keep the congenital heart diseases away. But sometimes even without an inherent congenital heart disease, there might be decreased left ventricular function, like in asphyxia, like in sepsis, or like in congenital diaphragmatic hernia. So those are the reasons why babies may develop PPHN. Now, if we were to look at the etiology closely, then meconium aspiration syndrome in low-income countries as well as in the world over is the major, most important cause of PPHN. Babies who have meconium aspiration syndrome are at the greatest risk for developing PPHN. The other causes from the low-income countries, as you can see, are pneumonia and sepsis, asphyxia, and sometimes asphyxia and meconium aspiration are going hand in hand. And then other things like TTNB, congenital diaphragmatic hernia, being a late preterm, and other causes. And idiopathic, if you will notice in the other slide in this other one, which comes from the Western world, may make up to 27%. I said 10 to 20% may be idiopathic. So here they found that almost 30% would be idiopathic. So as we are finding out causes, then this idiopathic group is going on shrinking. And now we can find out the cause for so many things. Like maybe there is a hidden genetic cause. So we have not been able to find that out, but that can be delineated. So just putting all these things together in these beautiful diagrams from Satyan's publications. So you see one by one, you can see that, yeah. How does one get the pointer? Right. Okay, yeah. This one? Yes. Yeah, so we can see abnormal transition as happens in asphyxia, intrinsic obstruction as may happen with polycythemia, pulmonary hypoplasia that may happen with congenital diaphragmatic hernia, or in any condition which is causing oligohydramnias. For example, PROM, for example, renal malformations leading to oligohydramnios that causes the lung not to develop properly. So here you have pulmonary hypoplasia. And parenchymal lung diseases like meconium aspiration, like pneumonia, and sometimes an increase in pulmonary venous pressure because of left ventricular dysfunction. If the left ventricle is not functioning well, then obviously there will be an increase in the pulmonary venous pressure, giving rise to increased pulmonary venous hypertension. So transition at birth, Dr. Asutosh has already talked to us about this. Just let's put it a little differently. So what was happening before birth? There was compression of the pulmonary blood vessels by fluid-filled alveoli. There was a lack of rhythmic distension of the lungs. The fetus was not breathing. The vasoconstrictors were definitely much more than the vasodilators in the circulation. And the cuboidal epithelial lining of the vascular lumen in the fetus was making the lumen of the pulmonary vasculature smaller. So all these things were giving rise to an increase in the pulmonary vascular resistance. Then what happened? The baby was born. So he started breathing, rhythmic respirations happened, increased pulmonary blood flow, and increased oxygenation. All these things happened at birth. Because of these rhythmic respirations, Dr. Asutosh has already told us there is a mechanical distension of the blood vessels, the prostacyclines increase, potassium channels get stimulated and they open up, and we get vasodilatation. Then here, again, because after birth, there is increase. We were told that the blood flow increases 8 to 10 times. So with so much of blood flowing into the pulmonary circulation, there is shear stress. And because of that shear stress, the NO, nitric oxide, the prostaglandins, they increase, the potassium channels get stimulated. And these potassium channels are the ones that take care of the calcium that is coming out into the cytosol. So here they'll also cause vasodilatation. Then increase oxygenation. We heard that increased oxygenation is the single most important thing that reduces PVR after the baby is born. And here that also causes an increase in nitric oxide levels, stimulates the potassium channels to open up, and there is a loss of the pulmonary venous constriction that was happening, hypoxic pulmonary venous constriction that was happening in the fetal life. And that also causes vasodilatation. And so ultimately the PVR decreases. We've already heard a lot about this. So if you were to look at this picture, which I found from the net, then there are things that are happening before birth. This is the line that is indicating birth at term. So you can see that before the baby was born, that is the fetus came out, what were the things that were happening? The pulmonary vasculature was becoming more mature, surfactant was increasing in amount, nitric oxide production, capability of producing nitric oxide was increasing, and the response to oxygen was also improving. And so when the baby is born, all these things are at their prime. And so this thing, pulmonary vascular resistance decreases. And you see here that the vessels are more dilated and the baby is having no problem. There is no persistence of any pulmonary hypertension. This is what is happening at birth. Now comes this diagram. So here, what happens is that at birth, there are certain changes in the endothelial cells of the blood vessels. The pulmonary blood vessels, the ones that are going into the around the alveolus and everything. Then we have the smooth muscles, which are lining the pulmonary arterioles right from the beginning till the end. So there are certain changes that happen in these, in the endothelial cells as well as in the smooth muscle cells of this pulmonary vasculature. So we have two systems, one that causes vasoconstriction and the other that causes vasodilatation. So what happens is that as term approaches, the endothelial nitric oxide synthase gene expression, it starts expressing itself more as term approaches. Okay, the gene was there, but the expression was not there. So as term approaches, term gestation approaches, this nitrous oxide synthase gene expresses itself more. There is increase induced cyclic GMP. So initially the capability of the fetus would not be so much to produce that much of cyclic GMP. But as term approaches, the capability of doing that increases. Okay, so then what happens? We have cyclooxygenase and prostaglandin synthase, with the help of which prostaglandin is produced. This prostaglandin acts on this receptor, which is on the smooth muscle, and it stimulates adenylate cyclase, which is an enzyme, which changes cyclic AMP to AMP. And this reaction causes efflux of calcium and vasodilatation. Then we have another system which causes dilatation, and this is mediated through NO, nitric oxide. So we have the endothelial nitric oxide synthase, which is stimulated once the baby is born, and especially if he is born more towards term. And this causes production of nitric oxide. This nitric oxide, it causes certain changes in the muscle, in the smooth muscles of this pulmonary vasculature, and soluble, what is this? Guanylate cyclase. It causes, this is the enzyme which causes cyclic GMP to change into cyclic. It causes the formation of cyclic GMP, and this cyclic GMP, it causes efflux of calcium again into the cytosol, causing vasodilatation. Here also, so we have cyclic AMP coming from the prostacyclin pathway, and we have cyclic GMP coming from the nitric oxide pathway. And both of these, they cause vasodilatation, thus reducing the pulmonary vascular resistance. Then we also have another system that causes vasoconstriction to some extent. This is endothelin. So this endothelin, this is produced again here in the endothelial cells. It acts on two receptors. One is this one and the other is this one. So the one that is on the smooth muscles, it causes vasoconstriction, while the one that is on the endothelial cell, it stimulates production of nitric oxide and again vasodilatation. So these are the systems that are in place. Then this nitric oxide, it can also combine with superoxide, and it can cause the production of peroxynitrite. These can be supplied at the time of resuscitating the baby. So you're giving oxygenating the baby, producing free radicals of oxygen. And this peroxynitrite is again a vasoconstrictor. So there has to be a balance between the vasoconstrictors and the dilators. So normally in normal transition, the dilators would be working more than the constrictors. But if there is a disease or if there is a problem, then this may not be like this. So at birth, because of the rhythmic lung distension, because of the shear stress, because of increased blood flow and increased oxygen, all these changes are happening. Now, what happens if the baby develops PPHN? The function of the endothelium is impaired. And there is an imbalance between the dilators and the constrictors, with the constrictors having an upper hand. So if we were to look at what's happening in the alveoli, here the blood that is coming into the capillaries around the alveoli in the fetus, the PaO2 is just 18 millimeters, and here no oxygenation is happening. So the venous side of this is also having a PaO2 of 18 millimeter. Why? Because this is a fluid-filled alveolus, and the PaO2 in that is also 18 millimeters. Now, this is because of increased PVR in the fetus, because of higher levels of endothelin and thromboxane. What happens in the newborn? We know that he is ventilated. So here now the PaO2 is more than 100 millimeters. And so the PaO2 of the blood that is coming around the alveolus is 40, but that which is going out from the after oxygenation, the PaO2 has become 60. So this is what is happening, and this is all happening because PVR is decreased. There is more oxygen, there is nitric oxide production, and the prostacyclin pathway is also working. So what happens after birth? After birth also normally, this is what is happening to the musculature of these pulmonary blood vessels. In the fetus, you see that it's narrow, PVR is more. In the first week after birth, the lumen is becoming bigger. And as at 6 months, the PVR is decreased so much because of remodeling that happens in the pulmonary bed, even after the baby is born, into 6 months after the baby is born. So what are the abnormalities in the pulmonary vasculature because of which we're talking about the pathogenesis? So the vasculature may be underdeveloped. That's one thing. Then if it is underdeveloped in conditions like where there is pulmonary hypoplasia, for example, in congenital diaphragmatic hernia is the classical example. In other lung malformations, oligohydramnios. If there's oligohydramnios, we know that there is lung hypoplasia. That is one reason why SGA babies, they are more prone to developing PPHN. And FGR, that is the fetal growth restriction, and intrinsic obstruction like in polycythemia. So, or the blood vessels may be maldeveloped. Okay, so if they are maldeveloped, what are the conditions? Here, there is an abnormal muscle layer in the blood vessels. The lung is formed properly, the vessels are formed properly, but the muscularization of the vessels is not correct. Otherwise, the lung is okay. So when does this happen? This happens in idiopathic PPHN. For some reason, the muscular layer is more developed. Post-term deliveries and in premature closure of the duct, as may happen sometimes in the intrauterine line. Then there is maladaptation. Everything is normally formed, but something is going wrong at the time of birth, and because of which there is active pulmonary vasoconstriction. When will this happen? In which condition? Meconium aspiration syndrome, the parenchymal lung diseases, perinatal depression or asphyxia, then pneumonia, sepsis, RDS in the early stage, and TTND, transient tachypnea of newborn. So this is what is happening in the pulmonary vasculature, which is the underlying pathogenesis of the pulmonary hypertension that happens in some babies. So it's not that if you are having underdeveloped vasculature, it will be only underdeveloped vasculature. There can be different combinations of these three groups. And there may be more than one factor which is happening in a particular baby, which is causing PPHN. So let's talk a little bit more about PPHN, the pathophysiology in parenchymal lung disease. So we've already said that in parenchymal lung disease, the main problem is everything is normally made, but there is vasoconstriction. So in this picture, you can see that the muscle layer, the musculature in the airways is normal. It should be till the terminal bronchiole. It is till the terminal bronchiole. Yet there is pulmonary vasoconstriction. Now here, if you see, there is low lung volume. These are certain conditions with low lung volume, like RDS. There could be other conditions with high lung volume, like typically meconium aspiration syndrome. So in both these conditions, the blood vessels are compressed. So PVR is increased. So in these parenchymal lung diseases, the reasons may be for vasoconstriction, may be chemical pneumonitis, may be surfactant inactivation, may be pro-inflammatory mediators, presence of right to left shunts causing hypoxemia, and an increased level of endothelin and thromboxane. So what happens in TTNB? Here also there is a maladaptation. So newborns with TTNB who have hypoxemia, they are often given high FiO2s, 80%, 100%, without giving them any positive pressure, any PEEP. So in these conditions, there may be absorption atelectasis. And so the baby may develop PPHN. The formation of reactive oxygen species will also occur because you're giving them so much of oxygen, 80%, 100%. And because of that, there would be increased pulmonary vascular reactivity. Then there would be, in these patient babies, there would be severe respiratory morbidity, subsequent and even subsequent mortality. So patient who has TTNB, which settles on its own usually, 24 hours, 48 hours. So he may land up with PPH, especially if you do these things which we shouldn't be doing. 100% oxygen without any pressure. So there is this absorption atelectasis, development of PPHN, and this is known as malignant PPHN. And to prevent this, the best thing would be to give PEEP along with oxygen and not oxygen alone. So the vicious cycle of hypoxia in PPHN is this one. Hypoxia, hypercapnia, acidosis, cold causes vasoconstriction, which increases PVR, which again increases left to right shunts, which again increases hypoxemia, hypercapnia, acidosis. So it goes on and on like that. So now what happens in idiopathic PPHN? In idiopathic PPHN, what happens is, as you can very nicely see in this picture, that muscularization happens till the end of these acinar arteries. So acinar arteries, if they are muscularized till the end, then you can understand that PVR will be more because they are muscularized. The vascular proliferation of the smooth muscles in the blood vessels, which are extending into the intra-acinar arteries. This is the main reason for developing idiopathic PPHN. There is vascular remodeling with abnormal muscularization. That is what. Muscularization is occurring till the end, till the intra-acinar arteries. Remodeling, the tunica media has become so thick. So that is the reason why PPHN happens, and even the adventitia. So the cause is not known. 10 to 20% may be idiopathic, and increased vascular muscle proliferation is the reason, and which are extending into the intra-acinar arteries. Premature closure of PDA, people thought, would be because of NSAIDs, aspirin or SSRIs, but this has been found कि ऐसा नहीं होता है. So now this is a question mark, whether this is a reason of for closure of premature closure of PDA and PPHN. We have a paper for that. Then decreased production of nitric oxide because of something wrong with the urea cycle. You know that L-arginine is the product from which nitric oxide is made by the endothelial nitric oxide synthase. So if there's no L-arginine, then there would be less production of nitric oxide. And we all remember that L-arginine comes from the urea cycle. So a silent defect there may be the reason for something that we are labeling as idiopathic PPHN. And then decreased responsive. There may be an inherent decreased responsiveness to vasodilators. So this is the paper I was talking about. So they found as long ago as 2013, and we still go on enumerating that as a cause for developing PPHN, that probably it has got nothing to do with PPHN. Then we also said that sometimes there is underdevelopment of the pulmonary vasculature, which may be the cause for developing PPHN in the baby. So here you have the classical example of congenital diaphragmatic hernia. You can see that the lung is not is hypoplastic. And why does this happen? Because there is a developmental arrest in the normal pattern of airway branching, impaired alveolarization, and impaired pulmonary arterial branching, and loss of cross-sectional area of the pulmonary vascular bed because of and thickening of the media and adventitia of the arterioles. These are the reasons. So they're similar. So you may be mixing up between the three types, and mortality is very high, especially if the baby develops PPHN. So now the question of why PPHN in the premature baby. So classically it should happen in the term baby or in the late preterm baby. So why the preterm baby? So here we found that increasingly extremely preterm neonates, especially those babies who have RDS, they develop PPHN early on. And PPHN, which is complicating RDS later on, when the baby is developed BPD, till now was thought to be something distinct. Okay, this is not PPHN. This has happened because of RDS, and it's happened 2-3 weeks after the baby got RDS. So it's got nothing to do with the classical PPHN. But more recently, they found that early pulmonary hypertension in extremely preterm infants is associated with BPD with late pulmonary hypertension. Matlab, those babies who are preterm and develop PPHN early on, if later on they develop BPD, they'll be at more risk of developing PPHN. So the two things may have a common link, and that common link would be an abnormal vascular development or function. So if there is an abnormal vascular development and function, then that was there at birth, and that was there when the baby developed BPD also. Then PVR is high during the canalicular stage. Just look at this picture here. So we have the various stages of development of the lung. And here you have the red things, which are the vessels that are developing. So if the baby is in the canalicular phase up till the 26 weeks or so, you see, look at the size of the vessels that are around the canalicular airways. So PVR is high during the canalicular stage due to paucity of pulmonary vascular network and increased acinar arteriolar muscle thickness. Pulmonary vasculature at mid-gestation is also less responsive to oxygen. Look at this thing here. The mother is given oxygen. There is no difference in the pulmonary blood flow in the fetus. While later on it becomes, if you give mother extra oxygen, then this is what happens to the pulmonary blood flow. It increases. So there is decreased responsiveness to oxygen in a preterm at mid-gestation. Then there is associated FGR and PPROM with oligohydramnios with varying degrees of pulmonary hypoplasia. And they found that cord blood angiogenic factors like placental growth factor and VEGF are decreased in neonates who are exposed to placental underperfusion and predict the development of pulmonary hypertension. So these are the reasons why preterm babies may be developing, they develop PPHN. So these are various pictures from a term baby, from a preterm baby, and from a baby who has BPD. Look at the alveoli, all far-fetched, idhar udhar, dur dur, and look at the blood vessels. So we also said that if there is increased left atrial pressure for any reason, then also there can be PPHN. We said that certain conditions like which cause left ventricular dysfunction, they would be producing an increase in left atrial pressure. So you're not talking about the congenital heart diseases, but diseases where the left ventricular function is less. So that could also be a reason for this thing. pulmonary hypertension. So my take-home message is simple, that pathophysiology of PPHN is complex, and it is important to know the pathogenesis if we want to prevent PPHN and also when we are managing babies with PPHN. I think I'll stop here. Thank you so much.